Okay, we were going to the procedure index and we were going to look up code 39.29. So if you haven't gotten there yet, please flip over to your procedure index in the very back of the book, 39.29. And when we get there, we're going to again look and see what's included in that code. Is a brachial bypass included in 39.29?
Yes.
Yes. Is a bypass graft of the femoral popliteal arteries? Yes. Is a vascular bypass not otherwise specified included? Yes. Is a bypass graft included? Getting diverse answers here. Why do you say yes? Why do you say no? But what do you see behind the bypass graft? A colon. What does a colon mean? It's got to be modified by something else. So just bypass graft wouldn't work. Popliteal bypass graft. Yes, that would. So just the bypass graft wouldn't work because there's a colon behind it. It means it's got to be followed by some other terms following it. All right, there's some more words that we talk about conventions. Every time you see the word and, you're supposed to think and or. Why didn't they just print and or? I don't know. That would have been the easy thing. So when we see that it's a fracture of the ulna and radius, does that mean that in order to use that code, it's got to be a fracture of the radius and the ulna? Or, that's right, it doesn't. It can be and or. So it's a big grouping of every fracture of that radius could be here, every fracture of the ulna could be here, or it could be both the fractures. Make sense? All right, due to. When something is due to, it is caused by or secondary to. There is a causal relationship. There are certain things that you will learn throughout this book that have a causal relationship that we just accept. A diabetic cataract, is that caused by diabetes? Yes, it's due to it. We will have some times that our assumptions are made, and as we go through the book, whenever that's relevant, we'll stop and talk about it. It's not the kind of thing we want to go into right now because you've got a lot of those things coming up. The words with, or words like with mention of or associated with, means that both of the elements have to be in place. Influenza with pneumonia. Do I have to have influenza and pneumonia? Yes. If it said influenza and pneumonia, would you have to have both? No. If it was influenza or if it said pneumonia due to influenza? Yeah. Okay. So watch the words. That's all you got to do. All right. That brings us to Chapter 3. What we know is the UHDDS, the Uniform Hospital Discharge Data Set. To understand why we have it, you really need to understand how it was before we had it. So I'm going to take you back to before 1983, okay? Before DRGs. I'm going to take you back to the mid-70s, actually. And that's when I graduated from college, so you can tell I've been around a long time now. Back when I graduated from college, from RHIA program, and started my first job, and we started talking about coding, one hospital might decide that their principal diagnosis was the diagnosis that costs the most money to the hospital. Another hospital might say, well, their principal diagnosis was the first one that the patient had when they came in. Another hospital might say that their principal diagnosis was the diagnosis that the last one that the patient left with. Wait a minute. Could we then compare data from one hospital to another? Absolutely not. Because it was apples and oranges. Because nobody had an idea what everybody else was doing, and everybody was doing something different. Because there were no set guidelines. So you have to realize that back when I graduated from college, like in 1974, the only computerization that was in your health information department was something that we called the PAS, the Professional Activity Study. And it was actually put together by a group of people involved with the Kellogg Foundation, Kellogg like Tony the Tiger, in Battle Creek, Michigan, and they had big, humongous supercomputers there. And for a certain amount per discharge, we would fill out an abstract form by checking little boxes about things about the patient. Then we'd batch them up and we'd send them to their computer where they'd run them through their computer, and every 3 to 6 months we'd get printouts back that would give us information about our patients. Well, that was wonderful, because before then you literally had to do it manually in these trays that you pulled out and made these pencil markings and things. So that was a major improvement. This is unheard of to you all, because you sit down at a computer and get the data right there about your patients. But I'm trying to give you the historical perspective of where we've come. So all this was going on, everybody was doing things differently, and we knew we couldn't compare data, so they knew that in order to implement any kind of reimbursement system in the future, we were all going to have to be on the same page. And so the development of the UHDDS came about. And in this way, we had a minimum set of data that everybody had to subscribe to. All right, the UHDDS requires the following items. I'm on the middle of page 21. A principal diagnosis, which we've talked about earlier tonight. Other diagnoses that have significance for the specific hospital episode, and all significant procedures. Okay, now where did all this come from? We go back to those 4 cooperating parties that we talked about last week. They got together, they helped develop the UHDDS, and the UHDDS is a core of very specific information that is gathered in a very specific manner so that we can begin to compare it from one healthcare facility to another. Now, the UHDDS definitions came about in 1985 for hospital reporting of inpatient data elements. Since that time, these definitions have been expanded to include all non-outpatient